Good afternoon, everyone. My name is Irene from Infection Control Department. I would like to welcome you on our lecture topic discussion for today, identifications of infectious disease processes. Hello. Okay. These identification processes is about number one, reducing the risk of HAI. Second, number two, immunocompromised patients. The Bordetella pertussis, the CD, which is your Clostridium difficile, and viral hepatitis, influenza. This, I mentioned, those topics are included in our identification of infectious disease processes. And let's start for this discussion. I will go first on the first part. Actually, this topics is having 4 chapters. But anyway, to make it short, I just present you by PowerPoint. Now I will start sharing to you the PowerPoint. We are now I have more on theoretical discussion for today. In this, I would like to share to you because all of this topic, I use this and I prepare this for my incoming board for infection control certification. And let's start. We will start first on the first part. Okay, let's start for this. The part one, the reduced risk of HAI, which is your healthcare associated infections. Understanding the risk factors, and those risk factors I will discuss to you later, that facilitate the transmissions of infections agents. This is important for preventing the spread of these microorganisms in various healthcare settings. In addition, the recognition of risk factors supports determining the need for additional interventions when patients got colonized or infected with this microorganism and enter to healthcare facilities. This understanding is also key for HAI infection. Surveillance data that adjust for certain infection risks and are used for inter-facility comparisons of infections rates comparisons inter-facility. What does it mean? This is why your call your surveillance monitoring. That's why, example, in one area like ICU, comparison of infection rates, which is your surveillance monitoring. This knowledge then aids in the development and implementations of interventions to mitigate the transmissions of infections. The risk of HAI during patient care is related to the mode of transmissions of the infectious agent, the type of patient care activities, including medications being including medications being received or procedures being performed, the compliance with recommended practices, the cleanliness of the environment, the training and experience of the healthcare personnel, the staffing ratio, and the patient's underlying host defenses. Some patient factors. I mentioned the risk factors, and this is the one example, the patient factors that increase the risk of transmissions within the various healthcare settings and in the patient's own environment include immunosuppressive diseases and disorders, malignant disorders, your poor nutritional status, the AIDS, diabetes, pregnancy, the travel history is included, occupation, contact with certain pets or animals, extensive burn wounds, the last one, the trauma. The medical interventions have also been shown to have an influence on the patient's risk of infections, including presence of invasive devices, placement in an intensive care unit or ICU, exposure to antibiotics or certain medications, immunosuppressive therapy, the length of hospitalizations, staffing ratio, the experience and training of care provider for certain device-associated infections. The increased number of healthcare personnel examinations procedures. More recently, the research has demonstrated that by strict compliance with recommended bundles of care, recommended practices for management of specific devices, and in surgical care, the risk of infection can be reduced. Or conversely, patients are increased risk for infection if these recommended measures are not strictly followed by 100% of the time. Yes. It will start from the agent, the reservoir, the place of exit, the mode of transmission, place of entry, and susceptible host. And this is the chain of infection. Hmm. The chain of infection can be broken. It start where we found the microorganism, the reservoir, the exit point, transmission route, the place of entry, and susceptibility. From microorganism, which what are those? These are bacteria, fungi, protozoa, viruses, and prions. And reservoir that people in food and equipment, water. The exit point is where it goes to down to body fluids, either skin or droplets. The transmission route is your direct contact, ingestion, airborne or mites, and the place of entry is your mucous membrane tract, GI tract, respiratory tract, or broken skin. The susceptible host, the immunosuppressions, diabetes, immobility, age, surgery, cancer, normal flora suppression. And then goes again where microorganism. What's this? This is the identification of organism. Huh? Should be appropriate antibiotics for microorganism. And so reservoir, its immunization, the staff health, the hygiene, the environmental cleaning, the food safety, disinfection, sterilization, engineering, monitoring. An exit point, again, and hygiene. This includes your waste disposal, control of body fluids, then personal protective equipment. And transmission routes include your isolations, personal protective equipment, the food handling, the airflow control, disinfection, sterilization, of course, this hygiene. Again, in the place of entry, this includes your catheter care, and hygiene, wound care, skin preparations, aseptic procedure, and then personal protective equipment. And the last one, the susceptible host. These include your nutrition, mobilization, the safe practices, and isolations. This how treatment of underlying diseases, recognition of high-risk patients. Okay, now this what you call the chain of infection can be broken by this cycle pattern. I think if you know some points to be reviewed. Example of this J. You can apply your acronyms here. MRETPS. That's what I did. Because of course I cannot memorize it in one click. Just as long as you understand this pattern and make your own acronyms so that easy to remember. If you say MRETPS, I do it that. And I will share to you the experience how I did in my review. Then the risk factors for infectious transmission. Infectious agent first, okay? We will discuss each. Now, there are several characteristics that influence the transmissibility of an organism and its ability to cause diseases. Again, there are several characteristics that influence the transmissibility of an organism and its ability to cause disease. We start with the virulence. What is virulence? It is the ability to grow and multiply. Infectivity, the ability to enter tissues. Pathogenicity, the ability to cause disease. Pathogens. Durations of exposure, just the length of time the person is exposed to the organism. The size of inoculum, the number of organisms needed to cause disease. Okay, this is number one, the infectious agent. Next, the reservoir. All organisms have a place where they can exist and reproduce that facilitates their transmission. This includes human, animals, insects, food, environment. What I said. Organisms have a place where they can exist and reproduce that facilitates their transmission. This includes humans. Within humans, the Streptococcus pneumonias, Staphylococcus aureus, and CD, which is Clostridium difficile. In this include your multidrug and DRO, multidrug resistant organism. Animals, pigs, swines, influenza, birds. All categories the birds, avian, influenza. Pigs, swine, influenza. Dogs, parasites, and worms. How about the turtles? Salmonella and bats, rabies. The insects, the babesia, the malaria, the Rocky Mountain spotted fever, West Nile fever virus. The food is Cryptosporidia, Cyclospora, Salmonella, and Listeria. Internal and environment, there is internal and external. In internal, this is inanimate objects. The Clostridium difficile, dust. Aspergillus. This, the water, Legionella. External, the soil, valley fever, plant stems, Sporotrix. I see these internal and external in the questions on my review. The portal of exit. Next in the chain of infection, an infectious agent needs a means to exit from its reservoir. The respiratory, gastrointestinal, weather, natural disaster, and inanimate objects. In respiratory, sneezing, coughing, and biting. Gastrointestine, gastro, gastrointestinal, sorry, feces. In the weather, there's wind and rain. Natural disaster, for example, is earthquake. And then inanimate objects, your contaminated skin. The mode of transmissions. Transmission-based precautions have been designed to address the specific routes of transmissions for a variety of diseases. An updated isolation guideline from the HII control practice. The recommendations, though the indicated personal protective equipment, the gown gloves mask upon entry into the patient's room for patients who are contact or droplet precautions because the nature of interactions with the patient cannot be predicted with certainty, and contaminated environmental surfaces are important sources for transmissions of pathogens. The guidance on the applications of precautions and settings other than just acute care, home health, ambulatory, and long-term care, etc. That's the mode of transmissions. Now, we are in the portal of entry, where it comes dwelling urinary catheters, intravascular devices, ventilators, the surgical procedures performed within or outside the operating suites, contaminated food, contaminated water, coughing in the face of a healthcare provider, tracheostomy care, dressing changes. The susceptible cause to anatomic physiologic factors, specific and non-specific immunologic deficiencies, risk of aspiration due to functional or chemical disorders, GERD. What is GERD? Gastroesophageal, reflux disease, oropharyngeal incoordinations, neurologic disease, weakness or fatigue in the pulmonary musculature, trauma, the extensive third degree burns, the malignant disorders, asthenia, the urinary retentions, incomplete evacuations with or without vesiculated reflux, diabetes, malnutrition, poor nutritional status, age, and gender. Next, medical interventions factors. This includes your surgical invasive procedures, the type and durations, indwelling devices, medications, stays in a critical care unit, length of stay, the experience and education of healthcare providers, the staffing ratios, repeated number of examinations by healthcare providers, teaching institutions, the appropriate device cleaning for disinfection and sterilization. This is the sequence. Cleaning, disinfection, and sterilization. Number three, your environmental factors. Stay in a room previously occupied by a patient with a multi-drug resistant organism, which is your MDRO, MIDRO, or CD, Clostridium difficile. I told you we are now more on theoretical discussions, so I mentioned all the types of pathogens um, described is on these infectious diseases processes. Okay. We continue. Clostridium difficile studies have shown significant transmission risk to subsequent occupants in a room that previously housed a patient with a metro or CD, the drug or CD. The type of disinfectant used. The compliance with hand hygiene, a simple basic step that's very, very effective. Hand hygiene. Use of barriers. It's me? A precautionary measure. Precaution. Like wearing PPE. One example of this. Okay. Thoroughness of environmental and equipment cleaning and disinfections. Contact with pets and animals is the environmental factors. The healthcare workers exposure is exposure to airborne infections the following situations. Exposure of HCW to airborne infections in the following situations. Admission of a patient with unrecognized airborne infections in a regular room. Again, admission of a patient with unrecognized airborne infection in regular room. Failure to use appropriate masks and in the fight to care for patients with airborne infections. Unrecognized incubating airborne infections presence on duty. Again, healthcare workers with unrecognized incubating airborne infections presence on duty. Visitors infected with airborne diseases as measles, chickenpox, or TB. Inadequate ventilation and engineering control, Engineering control of isolation rooms. Contamination of ventilation system with waterborne bacteria, Legionella that have contaminated water system. Potential exposure to blood-body fluid secretions and excretions during direct patient care or handling of specimens in laboratory in the following situations. The potential exposure to blood, body fluids, secretions, and excretions during direct patient care or handling of specimens in laboratory in the following situations. Contact with blood, body fluids without protective barriers. Breaks of barriers or malfunction of safety devices as laboratory safety cabinets. Safety cabinets. Healthcare workers being unaware of infection risks as a respiratory therapist handling patient with herpes zoster on the block without gloves. Inadequate hand washing after handling patient with enteric illness as hepatitis A or rotavirus in newborn. Again, inadequate hand washing after handling patient with enteric illness as hepatitis A or rotavirus in newborn. Is what area? Nursery. Handling of contaminated linen or biohazardous material without protections. Exposure risks to bloodborne infections through shock injuries as needle stick due to inappropriate handling or due to inappropriate disposal of sharps. Exposure without vaccinations or natural immunity to vaccine preventable disease patients, chickenpox and measles. Food poisoning or gastroenteritis after consuming food not adequately prepared and stored. Risk visitors and family. Exposure to airborne disease. Patient with unrecognized airborne infection is not proper is not properly isolated. Inadequate ventilations. Masks are not provided to visitors who isolated patients with airborne disease. Again, masks are not provided to visitors of isolated patients with airborne disease. Proximity to another visitor with unrecognized urban infection as a child in the prodromal stage of chickenpox presence, outpatient clinic. Family member or visitors involved in patient direct care undergoes same risk of healthcare workers from exposure to blood and body secretions and exhalations of patients. Other risks to visitors include pregnant women visiting mobile patient, child attending a visit to an isolated patient with communicable disease. Managing and reducing high risk. The Infection Control Committee shall establish and monitor compliance and effectiveness of comprehensive infection control policies and procedures. Vigilant and proactive surveillance for early identification of infection risks, focusing on procedures in the areas of high risk and adequate management of infected cases. All cases of unanticipated death or major permanent loss of function associated with HAI will be managed as a sentinel event. Root cause analysis will be conducted to identify system and process factors that lead to this event. Action plan will follow to address underlying risk factors and prevent recurrence. Implementation of standard precautions for all patients regardless of diagnosis. Hand hygiene is the single most effective measure to prevent healthcare associated infection. I mentioned this already on my first, I think my second slides. Implementation of recognized scientifically based on hygiene guidelines and laws from WHO and CDC guidelines. Issue World Health Organization and Clinical Disease Center guidelines. Availability of resources needed for controlling infection, soaps, disinfectants, containers, isolation facilities, PPE, vaccines, etc. Staff education about potential risks for infection and management. Patient education in involving patient in his care through Speak Up initiatives. Family and visitors educations. Patient placement in adequately spaced care areas. Isolation of known or suspected infectious cases in proper isolation rooms until cured or proven to be free. Protective isolations may be needed for certain patients with compromised immunity. Proper staff-patient ratio, especially in critical care areas. Staff health assessment upon hiring, including PPD. Screening for tuberculosis. Stop immunizations program covering hepatitis B, measles, the MMR, chickenpox, and influenza. Stop workers with illnesses that might be transmitted in the workplace shall be restricted from work until they represent no risk. Stop workers with illnesses that might be transmitted in the workplace shall be restricted from work until they represent no risk. Proper staff patient ratio, especially in critical care areas. Staff health assessment upon hiring, including PPD, screening for tuberculosis. Yes, it's already finished. Allowing only necessary staff in operation theater and limiting their movements. Allowing only necessary staff in operation theater, your OR, and limiting their movements. Maintaining positive air pressure in operating room with 12 air change per hour, of which 3 air cycles are fresh air. All air is filtered through HEPA filters and regularly checked. Treating treating remote infections before elective surgery. Control of blood glucose pre-operatively. Shorten hospital stay as much as possible. Improve nutritional status of patients. Preventing healthcare associated pneumonia through patient positioning. Frequent sanctioning of secretions. Minimizing intubations and days of mechanical ventilation. Preventing UTIs by reducing indwelling catheter days or use of condom catheter as well as use of aseptic techniques. Environmental cleaning procedures and agents used. Engineering control for safe water, ventilations, and sewage system. The use of safer devices and less invasive procedures. Aseptic invasive devices. Proper use of antibiotics according to policies approved by therapeutic committees addressing all healthcare specialties. Now we are in part 2. This is your immunocompromised patients. Yes. Yeah, and on part two to be continued. So sorry because I check some of my report here. Okay, part two. The immunocompromised patients have defects in host defenses that predispose them towards the development of severe, often life-threatening infections. Neutropenia is characterized by blood neutrophil concentrations that falls below the average range, less than 1,000 cells per cubic milliliter. The term neutropenia is often used synonymously with thrombocytopenia. A severely neutropenic patient is characterized by blood neutrophil concentrations that falls below 500 cells per cubic milliliter. Measures cares of immunocompromised patients shall be covered with the same precautions appropriate for all patients. The proper hand-washing hygiene shall be adhered to by personnel, visitors, and patients. Again, the proper hand-washing and hygiene shall be adhered to by personnel, visitors, and the patients. The number of invasive devices used and procedures undertaken shall be limited whenever possible. Any device shall be discontinued as soon as it is deemed unnecessary for medical reasons. Activities that may break cutaneous barriers shall be avoided. Operations from bed linen, careless tape removal, use of enemas, rectal medications, and rectal thermometers. The good oral hygiene shall be maintained. This includes teaching the patient about appropriate automatic oral care, using soap, toothbrushes, using soap, toothbrushes, and normal saline rings every 4 hours. Why you are using soap, toothbrushes, this is to avoid the patient from irritation, injury, or and then findings that appear suspicious and may be suggestive of infections should be investigated. They are temperature of 38 centigrade, neutropenic patients. Erythema and pain in areas were previously symptomatic. The pulmonary infiltrates and chest X-rays film without evidence of rails and consolidation. Definite decrease in the patient's level of responsiveness or sudden changes in mental status. Severe watery diarrhea, suggestive of CD. infection. Now, if severe watery diarrhea. Patients who are in bed rest shall be encouraged to turn, cough, and deep breath every 2 hours. Why? Why the patients who are in bed rest shall be encouraged to turn on other side, and after 30 minutes or hours, you will turn another side again. And must exercise the cough, the breathing processes. This to avoid why the patient need to be done to avoid bed sores. Patients with total granulocyte counts less than 500 are risk for infection from their own microflora. Efforts to reduce the risk of colonizations of the gastrointestinal tract with antibiotic-resistant organisms are appropriate. Sorry. Patients should be a private room if possible, in order to minimize contact between the patient and other individuals with potentially contagious infections. Medical staff with potentially contagious diseases shall not have contact with granulocytopenic patients. The granulocytopenic patient shall wear a mask when leaving her room, or she. Diet shall not contain salads, raw vegetable, or milk products. Water and ice shall come from sterile sources, if possible. Then strict hand washing shall be practiced before and after contact with patients. The plants and fresh flowers shall not be placed in the room of severely immunocompromised patients. In less immunocompromised patients, handling of flowers shall be designated to staff with the patient. Contact or gloves shall be worn by staff who handle flowers of plants. And pausing for 40 to 60 seconds shall be practiced after contact with plants. Base water shall be changed at least every how many hours? 48 hours. Base water shall be disposed into sinks that are not in the immediate environment of the patient. Sinks and bathroom fixtures shall be kept dry to prevent growth of bacteria. Sterile water shall be used for room humidifiers. No visitors with communicable disease shall be allowed to enter patient's room. No food shall be brought in from outside the hospital. Common infection agents in patients with cancer. We will differentiate between bacteria and fungi. In bacteria, the gram-positive organism, Staphylococcus aureus. What I said, common infectious agent, patients with cancer. Coagulase negative staphylococci, hemolytic streptococci, corynebacterium difficile, gram-negative organism, E. coli, Klebsiella pneumonia, Pseudomonas aeruginosa, Acinetobacter cacosticus, Pseudomonas multiplica, Enterobacter spp. And the fungi, Candida, Aspergillus, and Saccharomyces. Okay, bacteria, the Salmonella, the Mycobacteria, the Listeria, Cardia, and Legionella. Fungi, Streptococcus pyomonas, Histoplasma capsulatum, Clostridium immitis, and Protozoa, Pneumocystis, Carini, Toxoplasma, Conte, Leptosporidium, spp, Isospora villi. And the viruses is included the cytomegalovirus, the herpes simplex virus, varicella zoster virus, helminth, strongyloids, coralids, helminth, ito sa Tagalog, mga bulate, humoral immune dysfunction, recurrent respiratory infections, otitis, sinusitis due to bacteria encapsulated, the severe enterocolitis due to enteric pathogens, your Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitis. Humoral immune dysfunction. What is your acronym here? My acronym here is RSSS HN. It depends what ang kabatid. You can easy for me. RSS HN. Causes of neutropenia infections. Bacterial typhoid, paratyphoid, viral influenza, measles, infectious hepatitis, chickenpox, rubella, yellow fever, rickettsia, chickenpox, typhus, Rocky Mountain, spotted fever, protozoal is categorized to malaria and cala-ulcer. Overwhelming infections, especially in debilitated patients such as alcoholics or malnourished individuals. What I said, such as alcoholics or malnourished individuals. The miliary tuberculosis, pneumococcal pneumonia, and gram-negative bacteremia. This is the physical agents and chemicals and drugs. chemical and physical agents that always put us narrow, hypoplasia and aplasia. If given insufficient dosage, given insufficient dosage, ionizing radiation, Benson, antinatal phthalates like methotrexate, 6 mg chicorin and 5 fluorocycline. The antibiotics, lemomycin, adriamycin. Now, in chemicals, in chemicals and drugs, the patient will cause neutropenia, analgesics, anticonvulsants, Dilantin, anti-thyroid drugs, fluorouracil, and damazole. Anti-inflammatory agents, chloramphenicol, penicillins, sulfonamides, tranquilizers, methylphenidate, and then the last one, phenothiazine, chlorpromazine, and promazine. Hematologic and other conditions. Those due to decrease or infective productions, anemias, pernicious aplastic, chronic hypercholemic, and leukemia. Those due to increased utilizations, destruction, or sequestrations. Cirrhosis of the liver with splenomegaly. Lupus erythematosus, Colitis syndrome, Gaucher disease, hemodialysis. Aphasia and debilitated states, alcoholism, folate, folate deficiency, vitamin B12 deficiency, and copper deficiency. Thanks. So, I discussed the first part of infectious diseases, and then we will proceed to the second part, second chapter. It's number 2. I told you, and we start on this. We have 4 chapters, and by today only 2 chapters, and it will be followed on the next, third and the fourth. Just 5 minutes break. I will Hindi ko to take my water because I need to drink water. Hello everyone, I'm back. Let's continue. Hello? Yes. Hello, my test. Hello. Okay, let's start with the concentration. Now, Bordella, Bordetella pertussis. What is this? Pertussis epidemics occurs inside girls 2 to 5 years. Vaccination's immunity for pertussis weeks over time. Pertussis is highly contagious and has an impact on both the community and healthcare facilities. The diagnosis of pertussis can be made through direct culture, direct fluorescent antibody testing, or your PCR, polymerase chain reaction assay. Clinical manifestations of pertussis are broken down into two stages. What are those? The chiral stage and the paroxysmal stage. Vaccines for pertussis are available. You can take vaccines. Both community outbreaks and healthcare settings outbreaks have been reported. Okay. Pertussis. Whooping cough. Your whooping cough. Is highly communicable acute infectious respiratory disease caused by Bordetella pertussis. It is a small aerobic gram-negative pleomorphic bacillus, 0.2 to 0.5 in diameter. The bacteria is fastidious fast difficult to culture and have an incubation period of 10 to 14 days. Hypothesis produces multiple antigenic and biologically active products, including pertussis toxin, filamentous hemagglutinin, agglutinogens, adenylate, cyclase, toxin, Rituxan, Brimbia, tracheal colonization factor, tracheal cytotoxin, and which are responsible for the clinical features of pertussis disease. 1.22 closely related organisms are Bordetella parapertussis, which causes pertussis-like symptoms in humans, and Bordetella bronchoseptica, which causes respiratory tract illness in animals, although it has been occasionally reported in humans. It's including several cases reports. Patients saw a single case reported immunocompetent infant with recurrent pneumonia due to broncho bronchiectasis. Historically, historically, epidemics of pertussis have been found in the cyclic occurring every 2 to 5 years. Studies of pertussis in adults suggest that immunity following the pertussis vaccinations is not lifelong and that reinfection is common in both previously vaccinated and non-vaccinated persons. As a result, the increased incidence among the adolescents and adults that has been reported may play an important role in transmission of pertussis to susceptible infants. Immunity from childhood vaccinations means 5 to 10 years after the last whole cell vaccine dose, basically even up to 4 to 6 years of age. 12 years after the last dose of vaccine, there was almost no residual protection. The efficacy of the whole cell diphtheria tetanus pertussis vaccine, no longer used in the United States, estimated to be between 70 and 90%. Because pertussis is so highly contagious, secondary attack rates might exceed 80% among susceptible household contacts. Transmissions occurs by direct contact with respiratory secretions or light aerosol. Droplets from the respiratory tract of infected persons. The period of communicability starts with the onset of the lateral stage and extends into the paroxysmal 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 stage. It is important to recognize that pertussis is truly a worldwide disease that has no boundaries. Even with a global vaccination level of approximately 80%. It's not surprising because incidence and mortality rates are closely tied to the presence of immunization programs, concentrations, and the availability of quality medical care. Countries in which documented immunization rates have fallen have experienced an increase in incidence rates, and then decrease immunization rates may also pose a potential problem during a disaster if the disease occurred in a crowded refugee camps. Medyo written ba? I have to read the whole PowerPoint today. The gold standard technology of the laboratory diagnosis purchases is culture. What is the gold standard methodology? The gold standard methodology for the laboratory diagnosis of pertussis is culture, utilizing either trustworthy ginkgo or Regan low media. Okay. The specimen of choice is a nasopharyngeal aspirate or swab. Again, the specimen of choice is a nasopharyngeal aspirate or swab. The direct, if direct inoculation of the medium is not possible, specimens must be placed in Regan low transport medium, 1/2 strength charcoal agar, supplemented with horse blood and cefalexin, and stored at 4 centigrade until processed. The sensitivity of culture has been reported to range from 15 to 80% with lower performance if the patient has begun a regimen or effective antibiotic therapy, erythromycin, trematotene, sulfonylurea, azithromycin, or erythromycin. Or the specimens obtained more than 3 weeks after onset of cough. Direct fluorescent antibody (DFA) sounded like I don't know because it's not connected. DFA. Direct fluorescent antibody testing may be also used to diagnose pertussis infection. The test is highly specific at 98%. The sensitivity has been reported at 52%. Due to this low sensitivity, culture confirmations should be attempted if DFA testing is performed. What is DFA? Direct fluorescent antibody, not Department of Foreign Affairs. Okay. Okay, PCR, polymerase chain reaction. Tests for identification of adenopertussis are now rapid and specific. Again, PCR, polymerase chain reaction. Tests for identification of pertussis are now rapid and specific with a higher sensitivity than either culture or DFA. It is important that calcium alginate swab should not be used for nasopharyngeal collection if PCR testing will be performed because they have been shown to be inhibitory. What I said? If PCR testing will be performed because they have been shown to be inhibitory. Yeah. It's important that calcium algination should not be used for nasopharyngeal collection if PCR testing. If PCR testing will be performed because they have been shown to be inhibitory. PCR, despite being labor intensive, has been used as a rapid method to document HA healthcare-associated cases of pertussis. The enzyme-linked immunosorbent assay is this ELISA. Enzyme-linked immunosorbent assay techniques to identify serum antibodies to pertussis are another option for diagnosis. Techniques to identify serum antibodies to pertussis are another option for diagnosis if acute and convalescent sera are available. Okay, this is the optimal timing for diagnostic testing. X. Yeah. Control PCR and sensitivity. Serology, not sensitivity, sorry. Serology. There is signs symptoms, pertussis, whooping cough, can cause serious illness in babies, children, teens, and adults. Symptoms of pertussis usually develop within 5 to 10 days after being exposed, but sometimes not for as long as 3 weeks. Signs and symptoms of pertussis can cause serious illness in babies, children, teens, and adults. Symptoms of pertussis usually develop within 5 to 10 days after being exposed, sometimes not for as long as 3 weeks. The early symptoms. The disease usually starts with cold-like symptoms and may be a mild cough or fever in babies. The cough can be minimal or not even there. Babies maybe have symptoms known as apnea. Apnea is a pause in the child's breathing pattern. Emergency is most dangerous to babies. About half of babies younger than 1 year who get the disease need care in the hospital. Early symptoms can last for 1 to 2 weeks and usually include runny nose, low-grade fever, generally minimal throughout the course of the disease, mild occasional cough, apnea, a pause or in breathing babies. Because pertussis in its early stages appears to be nothing more than a common cold. It is often and not suspected or diagnosed until the more severe symptoms appear. Later stage signs and symptoms. Later stage symptoms after 1 to 2 weeks, and as the disease progresses, the traditional symptoms of pertussis may appear in include versus fits of many rapid coughs followed by high-pitched whoop. Again, paroxysms, feel of many rapid coughs followed by a high-pitched whoop, vomiting, throwing up during or after coughing fits. Then exhaustion, very tired after coughing fits. Pertussis can cause violent and rapid cough over and over until there is gone from the lungs and you are forced to inhale with a loud whooping sound. This extreme coughing can cause you to throw up and be very tired, although you are often exhausted after coughing it. You usually appear fairly well in between. After coughing it, you usually appear fairly well in between. Coughing fits generally become more common and bad as the illness continues and can occur more often at night. Can occur more often at night. The coughing fits can go on for up to 10 weeks or more. In China, pertussis is known as the 100-day cough. However, the hope is often not there for people who have milder, less serious disease. And the infection is generally milder in teens and adults, especially those who have been vaccinated. So it's important you are vaccinated. The infection is generally milder in teens and adults, especially those who have been vaccinated. Later stage symptoms next is disease progression for 2 to 6 weeks. In step 1, guttural stage, the one I told you. And then stage 2, paroxysmal stage. Guttural stage symptoms are involves low-grade fever, mild occasional cough, and highly contagious. Paroxysmal stage is symptoms fits of numerous rapid cough followed by wolf cough, vomiting, and exhaustion after coughing fits. And then step 3, I mentioned step 1, 2, 3. Step 1, what's that? Guttural stage. Step 2, paroxysmal stage 3, convalescent stage. Okay. The acronym for me is CPCB. CPCB. CPC. The CPC. Guttural paroxysmal convalescent. Then lasts about 3 to 4 weeks. In paroxysmal stage, symptoms for numerous cough, whoop sound, vomiting, exhaustions after coughing fits. In stage 1 to 3, sorry, stage 1 to 3. Lasts about 2 to 3 weeks. Susceptible to other respiratory infections. Recover is gradual. Coughing lessens, but fits of coughing might return. This is some medications. Azithromycin, erythromycin, PNP SMG. Okay. And we have dosing by age and durations. Azithromycin, duration 5 days. Azithromycin, huh? And then erythromycin, and erythromycin, PNP SAS. Preventions. Current Advisory Committee on Immunizations Recommendations Practices. The Advisory Committee on Immunization Practices recommends I license a cellular pertussis vaccine, which is your data, containing diphtheria, tetanus toxoid, a cellular pertussis vaccines for all 5 doses. Within the period tetanus pertussis vaccination series, and for the remaining doses in the series of children who have started the vaccination series with whole cell ETV vaccine. no longer available in the United States. The primary series data consists of 4 doses of the first 3 doses are given for 3 weeks with intervals, with a minimum of 4 weeks between the beginning of 6 weeks for 2 months of age. The fourth dose is given 6 to 12 months after the third. If the child receives all primary doses for turning 4 years and one of a booster. Those should be given before the child enters school. Does not lead to reductions in the level immunity, which on completions of the primary series there is no need to restart a series, regardless of the time that has elapsed between doses. Yeah. We will differentiate for adolescents and the pregnant women. For adolescents, recommendations for vaccinations of adolescents have also been issued. Adolescents 11 to 18 years of age should receive a single dose of Tdap containing tetanus toxoid, reduced diphtheria toxoids, and acellular pertussis. Children aged 7 to 10 years that are not fully vaccinated against pertussis should receive a single dose of Tdap. Okay? In pregnant women, the current recommendation is to vaccinate pregnant women with Tdap during every pregnancy, regardless of the patient's prior Tdap vaccination history, to provide the highest concentration of maternal antibodies to the infant. If Tdap is not administered during pregnancy, it should be administered immediately postpartum. All other adults recommends that all adults aged 19 years and older that have not received a dose of Tdap should receive a single dose again. All adults aged 19 years and older that have not received a dose of Tdap should receive a single dose regardless of the interval since their last tetanus or diphtheria toxoid containing the at this time, other than the pregnant women, ACIP is not making recommendations regarding yeah, the vaccinations of adults with Tdap. This is still being evaluated and is expected to be addressed in future. The CDC, which is your Communicable Disease Center and Prevention and Infectious Disease Experts, recommend the following guidelines for managing Bordetella reduces exposures. Implement droplet precautions. Implement droplet precautions in addition to standard precautions for suspected or non-infected patients. Cohort exposed patients. Provide post-exposure prophylaxis for all asymptomatic exposed employees, patients, and visitors, regardless of immunizations history. Evaluate all symptomatic employees for pertussis and provide appropriate antimicrobial therapy. For low symptomatic employees during the first 5 days of their therapy. More expansive measures are indicated when extensive outbreaks extend from the community in to the healthcare institution, and this include educate continuously within services on high-risk units via hospital newsletters and educational fact sheets, fax network to community physicians, and the news media. Distribute standardized checklists, forms, and guidelines developed by the infection preventionists. Can distribute standardized checklists, forms, and guidelines developed by the infection preventionists. Yours truly, I'm doing this. I'm doing checklists according to the standard references, and I do update and revise the complete guidelines. Then engage site B to assist the management of the exposure. Engage infection preventionists to assist with management of the exposures. Evaluate employees for respiratory symptoms and illness. Like example for our triage employees. Okay. Institute isolation precautions for patients admitted with suspected pertussis. Consider requiring all visitors to wear surgical masks while in the affected facility. Okay. Cohort patients displaying classic symptoms of coughing, etc. Said consider requiring all visitors to wear surgical masks while in the affected facility. We mentioned the surgical mask now. Yesterday we had memo. Now we can go outside without mask, but in the facility like it's closed, like a healthcare facility, we are still mandatory wearing surgical mask. But outside now you can remove mask. Example, you are in the beach. Now you can take without mask. You can go without mask. Sorry, that's we started yesterday. And then cohort patients displaying classic symptoms of cognitive. Now, restrict inpatients to the assigned unit Now I'm back. Hello. I think, one more. I think there is another one topic and then finish. Okay, to continue. This is the last part. It's the last part. Clostridium difficile infection and pseudomembranous colitis. Last part. Last part. Let's continue. Okay, let's continue. It's the last part. Okay. Clostridium difficile is a gram-positive, spore-forming anaerobic bacillus that produces two large toxins A and B, which cause diarrhea and colitis in susceptible patients whose normal colonic bacteria flora has been previously disrupted by prior antimicrobial treatment. Patient susceptibility to Clostridium difficile infections require prior antimicrobial treatment. Healthcare personnel transmit C. difficile on their hands. Spores may contaminate the healthcare environment. Patients asymptomatically colonized with C. difficile are at reduced risk of infections. Barrier precautions can be used to prevent difficile from reaching the patients. Environmental cleaning reduces spores contaminations and C. difficile infection incidence. Effective antimicrobial stewardship can effectively reduce C. difficile infection rates. Antimicrobial stewardships that we discussed the last week ago. Before I proceed to this topic, CD is an infectious bacterial diarrhea that occurs almost invariably in patients who have taken antibiotics recently, usually within 2 months. It was previously believed that the responsible organism is part of the normal flora and proliferates to cause disease when antibiotics are given. It is generally accepted that any hospitalized patients can acquire C. difficile organism, but for CDI to occur, It is necessary for the patients to have received antimicrobials that disrupt the normal bacterial flora. Certain cancer chemotherapeutic agents, which also have antibiotic activity, also place patients at risk. CDAD, CDAD stands for Clostridium difficile associated disease. That's acronym. Outbreak. An outbreak is defined as three or more cases of symptomatic CDAD cases occurring in the same ward unit within a period of 7 days. How many days? How many days? 7. It was said three or more cases. The risk factors in healthy adults, colonic bacterial flora is generally resistant to C. difficile colonization. If the flora is altered, resistant colonization is lost. Thus, factors associated with alterations of normal colonic flora increases the risk of disease. Colonization after exposure to the organisms. Risk factors. Tell you that this includes a history of recent antibiotic usage, especially clindamycin, ampicillin, cephalosporins, or additional frequent antibiotics exposure. Bowel surgery, chemotherapy, prolonged hospitalizations, increased age, serious underlying illness, or debilitation. Sorry guys. Case definitions or CDAD is laboratory confirmation of a positive toxin assay for C. difficile, together with diarrhea or visualization of pseudomembranes or sigmoidoscopy or colonoscopy or histological pathological diagnosis of pseudomembranous colitis. Diarrhea is defined as three or more loose watery bowel movements in 24 hours period, and the bowel movements are unusual or different for the patient. And there is no other recognized etiology for the diarrhea. For example, laxative use, inflammatory bowel disease. Then loose watery, if the stool were to be poured into a container, it would conform to the shape of the container. The modes of transmissions, of course, when the organism or the spores are ingested orally. This can occur from direct contact person to person, spread on hands, or from contact with the environment. Again, the mode of transmissions occurs when the organisms or spores are ingested orally. This can occur from direct contact person to person, spread on hands, or from contact with the environment. The incubation period is unknown. 1 day, 6 or more. Cohort. A patient cohort consists of two or more patients in a room together who are physically separated from other patients by their locations. That's cohort. A nursing cohort is a group of nurses providing care to a group of patients segregated from other patients. Okay. Diagnosis is your structure, cell cytotoxicity assay, enzyme immunoassay for toxins A and B, lytics test, colonoscopy, and nucleic acid. Okay, infection prevention and control precaution for difficile associated disease. Accommodations, All patients suspected of having that should be placed in a single room when dedicated toileting facilities, private room, or individual commode chair if available. Patients with confirmed may be cohorted. Cohorting should only be initiated or discontinued on the direction of Prevention Control and Infection Unit. The patient is in a multi-bed room unit. Sign needs indicating the precautions to be used should be visibly displayed. A barrier supply card should be easily accessible. A laundry hamper should be placed as close to the patient's bed space as possible. A commode chair should be dedicated for the patient's use. Okay, contact precautions. Signage indicating that contact precautions are to be used should be posted on the door or any room suspected confirmed patients or cohort of patients. Appropriate PPE. Gloves must be worn. Dedicated equipment, wheelchair, sleeves, scales, blood glucose meters, blood pressure cuffs, thermometers. In the event that any equipment must be shared through cleaning, followed by disinfectant. Okay, again, in the event that any equipment must be shared through cleaning, followed by disinfection of all such equipment with hospital-grade disinfectant. Approved for use with equipment must occur before use in another patient. 1 is to 10 Clorox. Temperature should not be taken rectally. Rectal thermometers have been linked to the spread of CDAD. No special handling of trays, linens, and waste required for patients. Commodes and bed fans must be handled very carefully to reduce spread of contamination with CD spores from the commode bed fan to the environment. Again, hand hygiene. Observe meticulous hand hygiene with soap and water. Soap and water is more effective in removing spores rub than alcohol-based hand rubs. So alcohol-based hand rub should not be used. So use soap and water. Environmental cleaning. All horizontal surface in the room, all items reached patients with suspected or confirmed should clean twice daily with 1 is to 10 Clorox. Particular attention should be paid to the cleaning of patient-specific items and highly touched surfaces. Cleaning must be thorough, taking into account the following principles. Work from clean items and surface to dirty ones. Okay, the physical application is necessary to remove CDBCD spores. Do not spray or squirt disinfectant solutions onto the surface to be clean. Change cleaning cloths and mops heads frequently. Disposable toilet process should be used in the rooms of all patients. Of course, you need to dispose of disposable. It must be disposable. Discharge transfer cleaning must occur upon resolution of CDAD symptoms or when the CDAD patient has the room changed or in discharge from a room. Cleaning of privacy, shower and window curtains must be taken down and sent for laundering. All disposable items including paper towels and toilet paper. Toilet brushes must be discarded as part of the discharge transfer cleaning process. Use an EPA registered hypochlorite-based disinfectant for environmental surface disinfections in patient care areas. 1 household Clorox. Activities in patient's movement. Evaluate the risk and ongoing transmission in facility before allowing patient out of home. You need to consider the three C's when the patient or resident out of the room. Ensure that the patient's clothing are clean. Hands are washed, the area is contained, and resident is cooperative with hand hygiene containing containing bodily fluids. Okay, the visitors. Visitors should receive instruction from the patient nurse on CDPC lead the importance of hygiene and how to properly carry this out. If a visitor is providing care for the patient or having significant contact with the patient's immediate environment, gloves and gowns should be worn. What they will wear, the PPE. And what is that? The gloves and gown mask. Visitors should receive instructions from patient's nurse on the correct use of PPE. Visitor must not use the patient's bathroom. And visitor should not go into other patients' bed spaces. Yes. Patient transfer. Both transportation services and the receiving department must be notified of the patients. Will be on contact precaution. That's why we have here also a color-coded sign needs instructions for both the patient and for also the receiving area. Transfer of patient with CDAD to another unit facility must be accompanied by notice that the patient has this. That's the one reason why we have color-coded sign aids, precautionary measures. The contact droplet and airborne, the CDA. What is the contact color-coded? Green. Droplet, red. Airborne, blue. Okay. Acronyms, CDA. Contact droplet, airborne. And then precautions to accompany a patient with CDAD and transits include gown and gloves. Cleaning of all equipments, stretcher, bed, wheelchair, used for the transfer before use with another patient resident. Patient discharge. Patient will go home. After discharge, patient will CDAD are not concerned for other family members as person-to-person transmissions without setting is rare. Uh, Good hand hygiene practices should always be exercised by the discharged patients and family members. Educational tools for patients and family regarding proper hand hygiene should Should what? Should discontinuation of precautions for C. difficile. Should patients with suspected CDAD patient on precaution measure for CDAD? Patient with confirmed CDAD contact precautions may be discontinued when the patient has had at least 48 hours without symptoms of diarrhea. The contact precaution should be discontinued only under the direction of prevention and control of infection. Okay. In patients with suspected DAD, precaution should be maintained until such evaluation has taken place. The recurrence of symptoms. If a patient is recurrent CDAD, considerations may be given to leaving the patient in a single room accommodation even after resolution of symptoms. Thank you. Thank you. Okay. This is the topic that I discussed with you guys. It's very long because it was cases. And those aspiring infection control will want to take the board exam for IPC. This that will help. And I reviewed this stuff. That's why I shared to you also. I have more incoming topics, especially on the how to prepare the board exams for infection control and waiting for my turn. And this is for all. This is for all today. Hoping you learn my topics discussion for today. And I will have another one. It is will be continued. It will be continued. Another I still have chapter 3 and 4. As I mentioned, the viral hepatitis and the viral hepatitis also it's as you know type of hepatitis A, B, C. Anyway, that's all for today. And thank you for watching and attending my topic discussion since I think it's already See you in my next lecture talk discussion. Thank you for the who did a membership today. Who Narasi Omar. Thank you very much. And therefore, ending of this lecture today. Thank you very much. On Friday, I invited you guys. It's my birthday and my inay birthday. I will do celebrations. But this time is for games. We will do games on Friday. Inshallah. Happy birthday to my inay. Little games. And also happy birthday to me. Thank you for watching.